Sir,
Yes, sir. Please, sir.
can we?
Yes, sir. Please, sir.
Okay. Dear friends and colleagues, we are about to start yet another session of this Clinical Neurology Forum. And we have the Indira Gandhi Institute of Medical Sciences at Puducherry. Neurology department is presenting cases. And ahead of the department, Professor C.T. Suresh is here and will moderate, and he himself will be doing a case presentation, a video presentation. And we have Professor Justin, Professor of Neurology at Madurai Medical College, to chair the session and conduct the proceedings. Over to Professor Justin, and you can take over and conduct. Yes, sir.
Thank you, sir. Good morning, everybody. At the outset, I thank Professor V.N. sir for giving this opportunity. Good morning, Suresh sir. Shall we proceed with the first case, sir?
Yes, sir.
Yeah.
We'll start with a twist.
Yes, sir. A paraplegia with a twist. Over to Dr. Jayashree, DRNB neurology resident from IGGH.
Good morning, sirs.
Please.
Sir, shall I start, sir?
Yeah, please.
Please.
Good morning, sirs. I'm presenting a case of Mr. R, 25-year-old male, BTech graduate, electrical engineer from Tiruvannamalai. He presented to us with history of weakness of both lower limbs for past 6 months. So patient noticed difficulty in bending his left ankle upwards while applying a bike gear 6 months back. Upon noticing that, he tried to bend his right foot upwards and found that he could not do it. This weakness was insidious in onset, gradually progressed over the next 6 months. Now patient is unable to lift the toes of both the feet above the ground. He had difficulty in holding on to the slippers for the past 5 months. He was able to insinuate the feet inside the slippers without any difficulty and could feel the sensation of the slippers in the feet. And he noticed that after walking for a few steps, he had slippage of slippers from both the feet, of which he was aware and needs to bend down to correct it with his hand to continue walking. Along with these complaints, he had tripping of toes in both feet for past 3 months, which was insidious onset and gradually progressing. Initially, it was while walking fast alone, but now he has tripping while walking at his normal pace. He had one episode of fall due to tripping of toes of the right foot while walking 1 month back, and it was not associated with loss of consciousness, involuntary limb movements, or any trauma. There was no history of buckling of knees, twisting of ankle, difficulty in standing from squatting position. No history in difficulty in lifting head from pillows, no history of difficulty in mixing food, buttoning shirt, or combing hair, no history of difficulty in turning side to side, no history of difficulty in swallowing or breathing. Weakness of limbs was not associated with pain, thinning of limbs, enlargement of muscles, no diurnal variation, exercise intolerance, or fatigue. There is no history of muscle twitching, tightness or flailness of the limbs, no history of passing cola-colored urine. Patient did not have any sensory disturbances in the form of numbness, walking over cotton wool sensation, tingling, pin-pricking sensation, or burning sensation. Patient was able to feel clots over the body, appreciate mosquito bite, able to feel hot and cold water sensation. There was no history of unsteadiness while walking, no history such of wash basin sign, no girdle-like sensation or root pain. Patient did not have any history suggestive of cranial nerve deficits. No history of fever, headache, vomiting, seizures, neck pain, photosensitivity. No history of memory disturbances, behavioral disturbances, mood disturbance, delusion, or hallucination. There was no history of dry mouth, dry eyes, multiple joint pain, skin rash, oral or nasal ulcers. No hyperpigmented patches over the body. No history of excessive hair fall or cold intolerance. Past history, patient did not have any comorbidities like diabetes mellitus, hypertension, thyroid disorders, cardiac diseases, connective tissue disorders, childhood malignancies, tuberculosis, bronchial asthma in the past. There was no history of toxin exposure or chronic drug intake. Personal history, he consumes mixed diet, he is a non-smoker, no history of alcohol use in the past, and no history of sexual promiscuity. He is an unmarried person. Family history, this is a arrow mark shows the affected proband. There is no significant family history. No other persons in the family suffer from similar illness. His elder brother died due to accident. Other than that, no specific family history. Coming to summary, a 25-year-old male presented with history of chronic insidious onset, gradually progressing symmetrical lower limb distal weakness for the past 6 months, with one episode of fall due to tripping of toes of right lower limb, without upper limb, neck or truncal weakness, without higher mental function, cranial nerve, sensory, cerebellar and autonomic disturbances, without significant past personal or family history. Sir,
Yeah.
at this point, I am not sure whether the weakness is due to LMN or UMN involvement, sir.
Whether you have to say whether it is a stiff weakness or flail weakness.
Yes, sir. A patient did not give any history of stiffness or flailness of the limbs, sir,
Okay.
in history.
Okay. Because that gives an whether you can divide the axis into whether it is a UMN or LMN at the history itself. That gives a clue. Right. Okay.
Yes, sir.
Justin, we have 6 cases. So
Okay, sir. Right, sir.
What time adjustment?
Yes, sir. Yes, sir.
So I would like to proceed with the examination to confirm it, sir.
No, you were saying something. What were you saying?
That's what, sir. From history, I'm not very much sure whether it is UMN or LMN involvement, sir.
Okay.
So I would like to go ahead with the examination to confirm it, sir.
Based on the history, what is your axis?
Yeah, with LMN, what do you think it is?
Sir, patient has got bilateral lower limb distal weakness, sir. Lifting the more of
Yes, agreed. Go
yes,
ahead.
Sir. Yes, sir.
So what do you think it is?
Sir, a patient has got bilateral foot drop types weakness, sir. And associated with the one history of fall due to tripping of right lower limb, sir.
That is all okay. What is the anatomy?
Sir, patient anatomy, patient is not, sir, anatomy in the sense weakness.
No, lower motor neuron or you have told lower motor neuron, you want to tell whether it's a muscle nerve like that.
Yes, sir. Sir, if it is an LMN weakness, I would like to go with motor neuropathy, sir, and or muscle involvement, sir.
Which is your first choice?
Sir, since it's 6 months duration, first will be motor neuropathy, sir.
Okay, what has the duration got to do with it? Okay, it's anyway a symmetrical weakness, right?
Yes, sir. Yes, sir.
Without any sensory involvement.
No sense.
Yeah. So what would be your first choice?
Sir, one is distal myopathy, muscle involvement, or
Correct.
yes, sir.
Yeah. Okay, we are not sure about upper motor neuron.
Yes, sir.
So proceed. Sorry for interfering. Go ahead.
Yes, sir. Sir, upon examination, patient is conscious, alert oriented to time, place and person. No pallor, icterus, cyanosis, clubbing, pedal edema, lymphadenopathy. There was no neurocutaneous marker seen. BMI is 22.8. Height neck ratio was normal. His vitals were normal, sir. Head to toe examination, skin, hair, nail, tongue, teeth and gums were normal. No joint laxity, loose skin, excessive skin folds, no peripheral nerve thickening. Pes cavus was found in both feet, which got obliterated upon standing. Mild guttering seen over the dorsal aspect of both feet. So this image shows pes cavus in both limbs, sir, and which got obliterated upon standing, sir.
Continue.
Examination of nervous system, higher mental function was normal, MMSE 30/30. Cranial nerve examinations was normal, sir. Fundus even was normal. Coming to motor examination, bulk, there was no gross asymmetry between the limbs, sir, except for mild wasting present over the dorsum of the bilateral foot. Tone, upper limbs, both upper limb tone was normal, lower limb, hip joint and knee joint was normal, ankle joint had hypotonia, neck flexion weakness was present, it was 4-5, neck extension was 5/5, trunk, it was normal, sir. Power in upper limbs, shoulder, elbow, wrist joint was 5/5, finger grip was 100% bilaterally. Lower limb, hip flexion, abduction was 4 minus by 5, extension and adduction was 4 plus by 5, internal and external rotation was 4 plus by 5. Knee flexion and extension is 4 by 5. Ankle dorsiflexion was 2 by 5 bilaterally, plantar flexion and inversion was 4 minus by 5, eversion 3 by 5. Foot EHL, EDL was 2 by 5, FHL and FDL was 4 minus by 5, toe grip is 30%. Reflexes, upper limb reflexes were normal, no Hoffman or Watermark sign in the upper limb. Knee jerk was brisk bilaterally, ankle jerk was elicitable, no cross adductor or ankle clone is present. Superficial reflex, abdomen reflex was present, plantar bilateral mute. Sensory system examination, crude touch, pain, temperature, vibration, joint position sense were normal, Romberg's negative, cortical sensations were normally perceived. Cerebellar system, finger nose test was normal, no intention tremor, dysdiadochokinesia was absent, heel knee test was normal. Autonomic nervous system, no resting tachycardia or orthostatic hypotension, peripheral nerves were not thickened. No extrapyramidal signs like mask-like faces, reduced blink rate, tremor, hypokinesia, rigidity or postural instability. Glabular tap was accommodative. Gait, patient stance, step length, stride length, step width, cadence, arm swing were normal. Steppage gait was present with toe striking the ground first. Toe walking he was able to do. Heel walking he was not able to do. Cranium and spine examination was normal. No signs of meningeal irritation. So this is a video showing neck flexion weakness, sir. Neck flexion was weak, sir. Extension was normal, sir. This is a video showing knee jerk. Knee jerk was slightly brisk bilaterally, sir. This is a video showing gait of the patient. He has steppage gait with toe striking the ground first. Other system examination, CVS, RS and abdomen were all normal, sir. So coming to summary, after examination, patient had bilateral pes cavus which got corrected upon standing with the ankle hypotonia, bilateral symmetrical distal distal more than proximal lower limb weakness which was in pyramidal pattern associated with neck flexion weakness, bilateral brisk knee jerk, bilateral mute plantar, steppage gait was present, and patient had difficult heel walking with normal high mental function, cranial nerves, sensory, cerebellar, autonomic, extrapyramidal system without nerve thickening or other system involvement, sir. So with the above history and examination, it is a pure motor syndrome with intact reflexes and sensory system. So we had the following differentials. First one is motor CADP. Points for CADP are duration is around 6 months, symmetrical lower limb distal and proximal weakness with neck flexion weakness. But the point against for CADP is reflexes were all present, sir. Second thing is distal myopathy we consider because pure motor symmetrical lower limb weakness with neck flexion weakness was there. But again, the ankle jerk was present in the patient and duration is only for 6 months, which was against distal myopathy. Distal hereditary motor neuropathy was the next differential. Symmetrical distal lower limb weakness and wasting was present in the patient. That goes with the distal HMN. And however, ankle jerk is present and pyramidal pattern of weakness is against distal HMN, sir. We considered a variant of ALS, element variant, due to ankle hypotonia, distal wasting and weakness. But points against are no extensor plantar, no fasciculations, and no other absent reflexes were there, sir. And next is spastic variant of SACD. 6 months duration, symmetrical lower limb weakness without sensory involvement were points for SACD, spastic variant, while neck flexion weakness is less common with SACD, sir. Last is hereditary spastic paraplegia due to pyramidal pattern of weakness, but however there was no spasticity or extensor plantar, and neck flexion weakness will be less common in HSP, sir. So these were the differential considered, sir.
The last three need not be included at all because there is no evidence of hypertonia, no evidence of spasticity, no evidence of upper motor neuron involvement. So you don't
Yes,
need
sir.
to discuss the last three. Only the first three will be there.
Yes, sir.
Okay.
Yes, sir.
So,
Yes, sir.
amongst
sir.
the first three, continue your discussion.
Yes, sir.
And then
So first three were the top differential. So we proceeded with investigation,
no.
sir.
What is your impression among the first three? You will have to
Sir,
come to some diagnostic consideration. What would you think of? You
Sir,
can't run away with that.
Yes, sir. We consider distal myopathy and distal HMN as the differential, sir, top two. And motor CADP was also in our differential, sir. Distal myopathy because patient presented with the pure motor bilateral lower limb weakness in the form of foot drop and neck flexion weakness, which can be present in some distal myopathy, sir. And points against it is ankle jerk is present, sir. So that is against distal myopathy, sir.
Justin,
And
you question her.
Yeah. Tell me. Tell me, doctor.
Yes, sir. Next is motor CADP, sir. Since the duration is around 6 months and patient has got bilateral symmetrical proximal as well as distal lower limb weakness, sir, associated with neck flexion weakness. And the point against is again all reflexes were present, sir. Then
See,
the third.
you are bringing in ankle jerks for most of these conditions,
Yes, sir.
isn't it?
Yes, sir.
Ankle
Yes,
jerks
sir.
being present.
Yes, sir.
Now, which muscle is involved as far as the ankle jerk is concerned?
Sir, hamstring muscle, sir.
So, is it involved in this patient at all?
Not much, sir.
Then why are you harping on ankle jerk being present? Ankle jerks will be present because
Yes,
it's a selective involvement.
Yes,
Only
sir.
the dorsiflexors are affected.
Yes, sir.
So there's no reason for ankle jerks to be affected.
Yes, sir.
So ankle jerks being present does not exclude any of the above conditions.
Okay, sir.
என்ன ஜஸ்டின் நீங்க என்ன சொல்றீங்க?
Yes, sir. Because ankle jerk is normally it will be present only, sir. Here only a distal symmetrical weakness of the foot drop. If you examine carefully, if the dorsiflexion, if the EHL is more weak, it's better than the other dorsiflexors, then you can favor for a myopathy. If it is not so, all are equally, you have to go for a neuropathy. That is basic one. And here your point is between the distal myopathy or a hereditary motor neuropathy.
Yes, sir.
Right. But
Motor
there
CADP
are
likely. Motor CADP, DATS variant can be considered, but once again, DATS is more likely in the upper limb.
yes, sir.
Only these two things, I think, distal myopathy or distal hereditary motor neuropathy.
Again, this postural deformity, what do you think about that?
Sir,
The foot deformity.
yes, sir. Pescavus is present, sir.
Yes.
So that could occur in both, sir, distal myopathy as well as distal
So it
HMN.
shows that it is an early involvement before the bone malleability, the
Yes,
disease
sir.
has started. That's
Yes,
why
sir.
you are getting arch foot.
Yes, sir.
Pescavus. And you said why there is a pyramidal type of weakness. You said that means that there is underlying some clue is there.
Yes, sir. Yes, sir. Lower limb hip flexion was more weak than hip flexion and abduction was more weak than hip extension and adduction, sir. And knee, we didn't get any significant difference, sir. And again, in ankle, we had dorsiflexion weakness more than plantar flexion, sir.
There are some HSP variants who will have some type of this pyramidal weakness with distal wasting and weakness like a bilateral foot drop is there.
Yes.
That is, we can expect also. It's last
Sir,
choice.
So my question is it it's a pure motor syndrome?
Yes,
He has
sir.
got pescavus, distal wasting, mild proximal weakness, neck flexion weakness is also there, and brisk knees, and preserved sensation.
Allegation, yes, professor. No.
Why not ALS variant, sir? Why not
It is my question is whether it's some form of motor neuron disease or a motor neuropathy.
Sir, pyramidal pattern, maybe early ALS variant can also have this type of thing, sir. Weakness, sir. But neuropathy, pyramidal pattern of weakness cannot be explained much, sir.
Right, ma. Go ahead with the investigation.
So coming to investigation.
Suresh, you want to add something?
No, sir. Let us continue, sir. We have a lot of
Okay,
space.
okay.
Investigation, complete blood count RP2, LFT were normal, ECG echo was normal, creatine kinase was elevated, 785 units. Vitamin B12 thyroid profile was normal, ESR, CRP, RA factor were normal, CSF analysis was done, no cells, protein and glucose were normal, sir. MRI brain with dorsal spine screening was done, it was also normal, no brain involvement was seen, sir. So these are the images of MRI, all were normal, sir.
Right, next test.
Next is nerve conduction study, sir. Upper limb totally normal. Lower limb we had tibial CMAPs alone reduced. That could be due to wasting of the muscles, sir. Other than that, sural snaps was normal. F waves were normal, sir. Next we did EMG. EMG also did not show any specific pattern, sir. It was normal. So we proceeded with genetic testing. So
That's it.
yes, sir. Genetic testing showed ALDH18A1 gene mutation, which is suggestive of spastic paraplegia 9A variant, sir.
What about GNE?
Sir,
Did you ask for GNE gene?
Yes, sir.
sir,
GNE was
yes, sir.
Negative.
Negative, sir.
Okay.
Sir, shall I proceed with discussion,
Please,
sir?
please.
Yes, sir. Sir, mutations in this ALDH18A1 gene, which codes for enzyme pyrrolin 5 carboxylate synthase, was associated with a spectrum of disorders, which primarily involves the nervous system metabolism and connective tissue. It can be autosomal recessive or dominant in inheritance and manifests as spastic paraplegia or cutis laxa syndrome. So this is a flowchart showing the involvement of PCS enzyme, which is responsible for ornithine synthesis as well as prolin synthesis. Prolin synthesis required for collagen and elastin production. So we get a cutaneous manifestation in this disease. So the spectrum goes like this: hereditary spastic paraplegia, and cutis laxa syndrome. Cutis laxa is characterized by wrinkle, saggy skin, skin laxity, joint hypermobility, and developmental delays. Other overlap syndromes includes neurocutaneous syndrome and metabolic syndrome, sir. So coming to autosomal dominant spastic paraplegia, that is SPG9A, which is characterized by slowly progressive spasticity of lower limbs. Onset will be in adolescence or adulthood. Patient presents with gait difficulties, motor neuropathy, and dysarthria. Additional variable features may include cerebellar signs, cataract, pescavus, and urinary urgency. Subtle human signs may also be present. The highlighted part in red shows the presence in our patient, and MRI usually have cerebellar atrophy. Autosomal recessive is a severe variant, early onset, slowly progressive spastic paraplegia with global developmental delay and intellectual disability. Patient may have dysmorphic facial features, urinary incontinence, congenital cataracts, and short stature. And also, MRI shows periventricular white matter abnormalities and cerebral cortical atrophy and corpus callosal atrophy. So this shows the spectrum of HSP. Here, SPG9 falls under a complex type of HSP. And here we have a spastic paraplegia overlapping with neuropathy, sir, in HSP9. So coming on to our patient, we had ALDH18A1 gene mutation, which had allele status of heterozygous variant. So in heterozygous, it is not possible to have autosomal recessive inheritance. So this is not possible. So our patient had autosomal dominant inheritance. Either he can have spastic paraplegia 9A or cutis laxa or both. Our patient only had phenotype of SPG9A without cutaneous manifestation. Why no cutaneous manifestation is domain sensitivity, sir. This PCS enzyme has a domain called G5K domain, which has to have severe mutation or a specific disruption of prolin synthesis should be there to affect the collagen and elastin production, thereby causing severe skin manifestations, which is very, very rare. So that may be the cause why our patient did not have any cutaneous manifestation. So in our patient, we had, other than that, we had neck muscle weakness, which may be explained with motor neuropathy. Patient did not have any bladder symptoms, cataract, gastroesophageal reflux, no fasciculations or cerebellar atrophy. Probably we have seen the patient very early so that in due course he may get all these symptoms. So what next is patient had autosomal dominant inheritance. So it could be a de novo mutation or a familial inheritance. So we have to screen the patient's parents as well as the siblings to know whether it is inherited. And he's unmarried. While getting married, we have to go for genetic counseling also. And monitoring for cataracts, gastroesophageal reflux in the future should be done. Biomarker screening like low plasma levels of citrulline, ornithine, arginine, proline can be considered to confirm the diagnosis. So coming to literature search, around five families were found with SPG9A mutation, that is autosomal dominant, and and around five families were with autosomal recessive mutation, and 7 families were with autosomal dominant mutation. Total cases reported worldwide is around 30 to 60 patients. Cutis laxa syndrome, otherwise known as DBARC syndrome, reported totally is around only 32 cases. And no case report of adult onset SPG9 was reported from India till now, sir.
Okay.
Anyway, a very good presentation. We do not know much about it. Yes, Justin, you can go ahead. But Jayashree, you did a very good presentation.
Thank you, sir.
The idea of presenting this case is this case presented as a pure motor syndrome, sir. Pure motor, I mean, it was like LMN syndrome, except with distal weakness and with preserved reflexes.
Yes,
the
sir.
preserved reflexes was a clue, and also the other thing in this patient, the patient had neck muscle weakness. These two things prompted us to do the genetic studies, sir.
Yeah.
And ultimately, it became the spastic paraplegia. What presented with the LMN syndrome subsequently became a spastic paraplegia of post genetic testing. So that's why we named it as a paraparesis with a twist.
CTS, anyway, genetic studies has to be done.
Yes,
Whether
sir.
it was the features, unusual features, or even otherwise. Even to
Yes.
establish a distal myopathy,
Yes, sir.
the only test is going to be genetic test.
Yes, sir.
Yes, sir.
Thank you.
Well done, sir.
Thank you. Thank you, Jayashree. Next,
Thank you, sir.
We call Dr. Natarajan, DRMB neurology resistant. A diagnostic puzzle, not the usual suspect.
Sir, before going into this case, I'll just give few words, sir. This is a
Yes.
case for discussion, sir. I want all the consultants to debate on this case because it's a case of vasculopathy. We are not very sure whether it's atherosclerotic or non-atherosclerotic. I want valuable guidelines in future treatment for this patient, sir. Thank
Yes,
you.
sir. Please.
Morning, sir. I'm starting. Can I start, sir?
Yeah,
Durai,
please.
go, one go.
Yes, sir.
Full English.
Sir, I'm Dr. Natarajan from Department of Neurology, IGGH PGI. I'm doing a final year resident in Department of Neurology. I'm presenting a case. A 44-year-old gentleman, electrical engineer, running his own business residing in Puducherry. He came with the complaints of unsteadiness while walking and swaying to left side while walking for 3 days and clumsiness of left hand for 3 days. 3 days prior to the presentation, while getting up from the bed, patient noticed acute onset unsteadiness while walking and also associated with swaying to left side while walking. He also noticed clumsiness of left hand while reaching the objects. It was not associated with any diplopia, dysphagia, dysarthria, no regurgitation of food or change of voice. No history of tinnitus, vertigo, hard of hearing, no history of any cardinal sensation or was space sign, no history of any loss of sensation over the body, no history of pins and needle sensation. It was not associated with weakness, tightness or looseness of limbs, muscle twitching, no history of any bladder bowel disturbances, palpitation or postural giddiness, no history of memory disturbances, behavioral disturbances, no history of headache, seizure, altered sensorium, no history of any slowness of activity. Past history, he had 3 episodes of stroke before that. The first episode, which was happened 10 years back, that was around his 44 years of his age. There is a history of acute onset left upper limb and lower limb weakness with ataxia. Patient was admitted and evaluated. Initial CT, there is no finding. Then they went to Chennai and the CT angiogram was done. It was 10 years back, which showed right common carotid artery angiogram shows normal at bifurcation, but there is a 70% short segment stenosis and clogging at the right ICA at the cavernous segment with in situ lucency suggestive of thrombus. And left carotid angiogram shows clogging of ICA origin and at cavernous ICA. ACA, MCA, and other branches are normal. The subclavian angiogram.
Duraraj, one
Yes.
minute. You
Yes,
said
sir.
the CT scan showed right coronaradiata infarct.
Yes, sir.
So it was abnormal.
Sir?
Right coronaradiata infarct was seen in the CT scan, isn't it?
Yes, sir. Yes, sir.
Okay.
Not sir. MRI, sir. MRI, sir.
Okay, fine, but it was not normal.
Yes, sir.
Okay. Go ahead.
Yes. The patient was initiated dual antiplatelets, statin, and diabetic drug. That time, patient was diagnosed with dyslipidemia. His triglyceride level 486. So he was started high dose statins along with the fenofibrate, and patient was completely improved after 6 months, and he continued medicines. And after 10 years, that is 1 year back, the second attack, that is history of acute onset of visual disturbances with unsteadiness while walking. The patient was evaluated and detected acute infarct in left occipital cortex. That time also MRI shows there is a hyperintensities in flare, which is shown here, along with MRA, which showed bilateral ICA narrowing with the left PCOM and left right A1 segment of ACR hypoplastic. The patient, this time, in addition to the aspirin and clopidogrel, patient again developed one more stroke. In spite of the regular compliance to drug, patient was added cilostazol. Then 6 months back, that is 9.5 years after the first episode, patient had a third attack. History of acute onset of numbness and decreased sensation over the left hemi body and face, along with the ataxia. This time, patient had a right thalamus infarct. This T2 flare and DW images showing the acute right thalamus infarct. This time, patient was, in spite of 3 platelet aggregation inhibiting drugs, patient had a third attack. So this time, we suspected some embolic shock of undetermined origin. So we added anticoagulation and maintained the PTNR of 2 to 3. In spite of all these 3 antiplatelet drugs along with the anticoagulant, now the patient developed the 4th episode of stroke. Past history, patient known case of type 2 diabetes mellitus for 20 years, known case of CAD, which was diagnosed 5 years back. He underwent a PTCA to the left anti-descending artery. And he is also a chronic kidney disease, which was diagnosed 2 years back, and hypertension was detected 2 years back. No history of malignancy, connective tissue disorder, any other surgeries or trauma, and no history of any pulmonary tuberculosis. Personal history, he takes mixed diet, sleep and appetite normal, no tobacco or alcohol abuse, no sexual promiscuity. And family history, he born out of non-consanguineous marriage, he has 8 siblings, all of them having a diabetes, and 4 of them having a coronary artery disease, and one elder brother died due to stroke. So there is a significant family history of diabetes mellitus, coronary artery disease, and stroke in his family. And he has 3 kids, all are healthy and fine. And parents does not have any history of any coronary artery disease, but both patients are diabetic. Drug history, currently patient taking aspirin 75 mg, clopidogrel 75 mg, atorvastatin 40 mg, cilostazol 100 mg BD, fenofibrate 145 mg, along with he taking insulin to control the blood sugar, amlodipine 5 mg BD, atenolol 25 mg once daily, and acetrom he is taking, and the dose was adjusted to maintain the INR between 2 to 3. And recently he started prednisolone 10 mg once daily. Sir, I will discuss after the examination, sir.
Yes, sir.
Yes, thank you, sir. Head to foot examination, hair, skin, nail appears normal, no dysmorphic faces, no skeletal deformities, there is no tendon xanthoma or telangiectasia or cataract, nitric ratio normal. Vital system examination, pulse 89 per minute, regular in rhythm, normal volume and carrot, no radioradial or radiofemoral delay, all peripheral pulses were filled and equally on both sides. Blood pressure 110 by 80 millimeter of mercury, and respiratory rate 18 beats per minute, SpO2 98%. Higher mental function, millimeter score 28 by 30, all are normal. Cranial examination, almost all normal, except there is a nystagmus which is present towards the left side, which is horizontal, non-fatigable nystagmus. Motor system examination. Inspection, there is no obvious wasting or any winging of scapula or hypertrophy, tone normal, and there is a mid-arm and mid-forearm, mid-thigh, mid-calf circumference are bilaterally symmetrical. Power examination, upper limb, all movements are 5/5 and finger grip 100%. Lower limb examination, hip, ankle and knee 5/5, toe grip 90%. Reflexes, upper limb reflexes are present, knees are bilaterally present, ankle reflex absent. Superficial reflexes are conjunctival, corneal, palatal and pharyngeal reflexes present, abdominal reflex absent, plantar bilateral mute. Sensory system examination, there is a pain, touch, temperature, position sensor normal. Only the vibration sense is decreased below the level of the knee. That is also graded up to the level of the ankle and absent over the grade toe. Cerebellar system examination, there is no head tremor. There is a nystagmus present towards the left side and speech normal. Finger nose test, intentional tremor and dysarthrokinesia present on the left side and heel knee shin test present on the left leg. Rebound phenomena absent. Gait, in sitting, there is no swaying. While walking, he is faced towards the left side and also turning and standing, he is swaying towards the left side. Tandem walking impaired. Autonomic nervous system normal. No thickening of peripheral nerves. Spine and cranium normal. Other system examination normal. Summary, a 54-year-old male, a known case of diabetes, initially diagnosed 20 years back, presented with acute onset of swaying towards the left side with the clumsiness of left upper limb and left without weakness, sensory disturbances, cranial nerve involvement or bladder bowel dysfunction from history, with a past history of recurrent ischemic stroke, which is started at 42 years of age, that is 10 years back. Initially, there is a right coronary radiata infarct, then left PCA infarct, then right thalamus infarct, followed by there is a currently one in stroke with history of coronary artery disease, chronic kidney disease, dyslipidemia, with a recently detected hypertension, with a family history of diabetes mellitus, coronary artery disease, and one elder brother died due to stroke. On examination, iron mental function and cranial nerve system normal. Motor system examination normal, except there is a mild weakness of bilateral toe grip. Cerebellar system examination shows positive finger nose test, dysarthrokinesia, and impaired tandem walking with nystagmus. Sensory system examination showed impaired vibration sensation below knee, and other system examination normal. For the currently, the structures involved are left cerebellar hemisphere and vermis and its connections, and bilateral symmetrical distal lower limb sensory motor peripheral neuropathy, as evidenced by the bilateral toe grip weakness and diminished vibration sensation and absent ankle reflex. Sir, can I go for discussions?
Yeah.
Sir, a 54-year-old male with multiple comorbid conditions with recurrent episodes of ischemic stroke, the following differential diagnoses were considered, sir. Large artery atherosclerosis, recurrent small vessel disease related stroke, cardioembolic stroke, inflammatory related vasculitis, hypercoagulable state, infection related vasculitis, hematological disorder, genetic causes, arterial dissection, malignancy, and drug related and others. I am going to discuss one by one, sir. First, large artery atherosclerosis. The patient had a history of diabetes for 20 years, and he also had a future history of other atherosclerotic disease like coronary artery disease, chronic kidney disease, dyslipidemia, with the family history of diabetes and coronary artery disease. These are the investigation, which was urea of 66, creatinine 3, and the random blood sugar was 456. His liver function test was normal. The lipid profile, when the first time when was diagnosed, the triglyceride level was 486. And after initiation of statins and fenofibrate, it decreased to 200 initially. Again, this admission, it became 248, the triglyceride level. Serum cholesterol level, initially it was 360 and then gradually decreased to 180. Now it is 222. And complete blood count, CPK and thyroid function test was normal. This is a CT brain at now the current admission. There is a bilateral CT brain axial cut shows bilateral coronary radiata chronic infarct, right thalamus chronic infarct, left PCA hereditary chronic infarct. There is no acute infarct noted in this time. The MRI, T2 axial cut and FLAR images shows acute infarct in left cerebellar hemisphere. It's a coronal and sagittal section, which also shows hyperintensity test of acute infarct. It's a DWO image, which shows diffusion restriction in cerebellar hemisphere. It's FLAR images, which shows hyperintensity, which tells of chronic infarct. And this is the MRA image, which shows there's a toxicity of the left ICA along with bilateral ICA narrowing at cavernous segment of ICA, that is C3 segment of ICA, and also right MCA after bifurcation, it shows there is a narrowing of the vessels. MRA normal. And carotid vertebral Doppler, the right common carotid artery, near end there is a 0.7 millimeter block, and right ICA 2 and 1.2 millimeter block, and also distal ICA 2.2 millimeter block, left CCA 2.1 millimeter block. There is a high resistance pattern noted in the left vertebral Doppler. Transcranial Doppler was done for this patient. All blood vessels shows normal mean flow velocity and pulsality index, but the right MCA, the pulses forward shift torus pattern was noted, which suggests there is some proximal occlusion, which made there is a slow rising pulse. So from the history and investigations and the CT angio, which was taken 10 years back, which showed there is a more than 50% stenosis with the plaque, and the CVT Doppler of multiple small plaques with it. All we suggest the first probable diagnosis was a large artery atherosclerosis, and we were treating the patient with double antiplatelets, and we added another antiplatelet, and we also added the anticoagulant. But we, in spite of the treatment, in spite of the regular medications, and the sugars are controlled to normal level before this admission, and also triglyceride level and cholesterol levels also controlled, the patient had recurrent episodes of stroke. Because of the onset of the stroke at the young age, that is at the age of 42 years, and also multiple vascular territory involvement and recurrences with elevated ESR, we want to rule out the other causes. So we evaluated the patient for further. For small vessel disease, it is very less possible because most of the infarcts are very larger in size, and there is evidence of large artery atherosclerosis and also cortical involvement, which is very rare in Lachman stroke, and also elevated ESR and young age. We ruled out small vessel disease as less likely. For cardioembolic stroke, we evaluated the patient. There is no irregular pulse rate, or is there no any history of palpitation. Chest X-ray was normal. ECG, there is no irregular rhythm. This normal sinus rhythm was there. Echocardiography, normal. Echocardiography shows hypokinesia, but there is no dilatation, or there is no any thrombus, and there is no prosthetic valves, or no any evidence of infarctive endocarditis. And transesophageal echo shows there is no evidence of thrombus or any septal defect. Holter monitoring done, there is no evidence of any arrhythmia, and there is no fall in BP. So there is no evidence suggestive of any cardioembolism. So cardioembolic stroke is also less likely. For inflammation-related vasculitis, we suspected because of the young age of onset, and there is a recurrent ischemic stroke along with the raised ESR, and the MRI shows there is a narrowing of the vessels. Where the CT angio, which was done 10 years back, after that we didn't do any CT angiogram. The MRI angiogram, which shows there is only a narrowing of the vessel, but we don't know whether it's some concentric vessel narrowing or any eccentric block obstruction, and we didn't do any biopsy for that. But the investigation, ESR was 80, RA factor CRP was negative, and nerve conduction study normal, EEG normal. We did the vasculitis workup. The common vasculitis antibodies such as ANA, myelin peroxidase antibodies, P3, that's Wegener Anta, and E1 RNP. For Sjogren's SSA, SSB, MI2, CNP, JO for myositis-related vasculitis, and SL70, PMSCI. All investigations for vasculitis workup were negative. So we considered vasculitis-related vasculitis-related stroke is also less likely. Then infections such as syphilis, HIV, which can also produce vasculitis, but the report shows there is no evidence for HIV or syphilis based on the investigation. Then hypercoagulable state. Even though the hypercoagulable state usually causes a venous type of stroke, we did investigation to rule out the protein C, protein S, antithrombin T deficiency, all are not there. Homocysteine levels are normal. Factor V late mutation and prothrombin gene mutation was not detected. Antiphospholipid antibodies are negative. Then hematological disorders like sickle cell disease, leukemia, polycythemia, and some paroxysmal nocturnal hemoglobinuria all can present as recurrent ischemic stroke in multiple vascular territory. Peripheral smear was normal and there is no evidence of hemoglobinopathy. Then we did genetic study to rule out some genetic disease like CADASIL or some other moya disease or Fabry's disease. But genetic disease report came as combined hyperlipidemia, that is a familial hyperlipidemia, autosomal dominant. This type of disease can usually present with recurrent atherosclerotic diseases in the form of coronary artery disease, peripheral vascular disease, and cerebral vascular disease. In our patient, the patient had a coronary artery disease and cerebral vascular disease, which is actually occurring recurrent, along with the increased triglyceride, increased LDL, and increased cholesterol levels. Even the patient family members also have diabetes and dyslipidemia along with the coronary artery disease, which all supports the patient had a background combined hyperlipidemia, which may be the triggering factor for the atherosclerosis. And there is no evidence for arterial dissection and malignancy workup, because some malignancies which has a propensity to increase the coagulability of the blood stream. So that can produce a malignancy related strokes, and also certain tumor emboli can also produce strokes. So we investigated the patient, CT thorax, abdomen, ultrasound, thyroid, cyst X-ray, all were normal, and there is no evidence for tumor. And there is no history of any cocaine, heroin, or any illicit drug abuse or any alcohol abuse. And other factors such as whether it's a pseudo recurrence. Sometimes when the patient had 3 episodes of PCA territory stroke, usually there is a worsening of old deficit occur during the fever, hypoglycemia, dyslipidemia, but it was usually not associated with new impact. But in our patient, all the strokes are associated with separate impact, because so it is not a pseudo recurrence. So other factors which should be considered poor compliance to treatment. We repeatedly inquired the patient. Patient was taking regular treatment without any skipping, and whether it is resistant to treatment. Sometimes even after taking the 2 antiplatelet drugs like aspirin or clopidogrel. Resistant to treatment. Because sometimes.
Sir, please mute. Go ahead. Presenter, go ahead.
Yes, sir. Patient sometimes with the clopidogrel resistance, the clopidogrel can be ineffective because of the enzyme deficiency or coexisting other drug intake like proton pump inhibitors or some other enzyme inhibitor drugs. So we ruled out that also. There is clinically there is no features for resistance for treatment. And whether it is in paroxysmal AF, we did Holter monitoring to rule out the AF, that is normal, but loop recorder which should be done to continue the monitor the patient for 30 days. So from the investigation, we narrowed down the diagnosis to large artery atherosclerosis causing artery to artery embolism, which causing the recurrent ischemic stroke. But in our patient, we had a bilateral ICS stenosis, but there is no evidence for the posterior circulation in the angio, which was done 10 years back. But patient had one episode of anterior circulation stroke, but all other 3 are posterior circulation strokes. Even though the artery has a 70% narrowing in bilaterally, the patient had one stroke in the anterior circulation. And similarly, the genetic study shows combined hyperlipidemia, which also supports the patient has a high risk for dyslipidemia and atherosclerotic disease. So finally, we came to whether it is a large artery atherosclerosis related, artery to artery emboli related recurrent ischemic stroke, or any vasculitis which causing the intermittent vasospasm or permanent vasculitis related narrowing which causing the recurrent ischemic stroke, or any drug resistance or any other causes.
Yeah. in this scenario, which has involved the multiple territories, recurrence and positive family history, kidney involvement,
Yes.
heart involvement, we have to suspect more of genetic cause like Fabry is the first. And still,
Okay.
we are not in position to rule out the vasculitis because
Yes,
we
sir.
have to do a vessel wall imaging, whether it is inflammatory, is there, component is there or not. There, by looking at the vessel wall imaging, we can able to see that multiple areas where you can differentiate from the atherosclerotic plaque from the vasculitic and other things.
Yes, sir.
Is it
So,
Vijayan?
Justin, sir.
Oh, Justin. Okay.
Sir,
I would probably consider, I would not exclude still a cardioembolic. He has regional wall motion abnormality. It is in
yes, sir.
multivascular territory. And,
Yes, sir.
and we have to consider, as you have pointed out, a paroxysmal AF.
Yes.
That he had the stroke and he recovered very well suggests that this could be an embolic stroke where the recovery is very good without much of a deficit.
Yes, sir.
And second thing I would think of is a combined hyperlipidemia. These are the two things
Yes,
I
sir.
would consider. That would be my possibilities.
Yes, sir.
Sir, actually, there are two aspects in this case, sir. One is
Yes.
etiopathogenesis, and next is the treatment aspect. Regarding the etiopathogenesis, we strongly suspect there's a vasculopathy. I don't know the vasculopathy, which is atherosclerotic or non-atherosclerotic. Because despite 3 antiplatelets and 1 anticoagulant, the patient is getting a recurrent stroke and also 40 milligram of statin. We did 3 carotid Dopplers, and all the Dopplers, the plaques are not very, it's all echogenic, sir. It's not very echolucent and it's not friable. And the MRI also showed multiple vascular territory occlusion, and these occlusions were not reversible. And these occlusions were not reversible. So his ESR was consistently high. So we thought of inflammatory vasculitis.
But CRP was normal.
Yes, sir, CRP, but the ESR is consistently high and there is multiple vessel narrowing, sir, actually. Multiple vessel narrowing. And the strokes are of different arterial territories. Though, I mean, on paper, it looks like atherosclerotic related vasculopathy. And I think vasculitis has to be strongly suspected in this patient. And my question is, or my doubt is, or my incompetence in treating this patient is why he developed 3-4 strokes despite treatment, despite anticoagulation, despite double antiplatelets, despite statins, and should be considered, we gave him steroids, and despite steroids, he developed another stroke. And now my question is whether we should do a vessel wall MRI, CSF tap, and should we put him on Britumix tap for suspecting vasculopathy? This is my doubt, sir.
If it's an embolic stroke, you
Yes,
will
sir.
continue to have in spite of all the treatment which you have given. So
Sir,
we need to exclude an embolic stroke. One, as you said, paroxysmal AF is a possibility. I do not know whether he mentioned about a transesophageal echocardiography.
Yes, sir, that has been done and
Yes,
it's
sir.
normal.
Done, sir.
Okay, okay, right, fine.
We did a 45-minute TCD monitoring and that was also negative, sir. There was no hits.
Okay.
Of course, we have to do the loop recording that we haven't done.
Right. That it has not responded to regular
Anticoagulation too.
antiplatelets and anticoagulation. Probably suggests that it might be still an embolic one.
Okay. Sir,
Yeah, proceed with your argument, Suresh. Yes.
Hey, that's what, sir. I'm not arguing, sir. I've told my.
No, your discussion, not argument. Your discussion.
Sir,
So
can I just chat? Sir,
Yes,
Dr. Banu
Please,
here.
madam.
Yes, please. Yes.
Should you
Morning,
continue the 3 platelet inhibitor drugs with oral anticoagulation?
He's on board.
It's not
Madam,
serving its purpose. Can we reduce that drugs?
Madam, this patient, we put him on double antiplatelets, madam, initially, and he developed one more stroke. After the double antiplatelets, we added the third drug, that was silostazole.
Understand, with the third drug, with the oral anticoagulation, he still had one stroke, right?
Yes, madam. And that was 3 days
So,
before.
should you, okay, if possible, you can check for clopidogrel resistance and at least reduce one drug if it is resistant.
Yes, madam, we'll do that.
Because you're increasing the chance of hemorrhage also. Though
Yeah,
so
okay.
far, touch wood he has not had.
Okay, madam.
I don't know. Or maybe you want to try the newer one, ticagrelor.
Okay, ma'am. We'll do that.
Don't
madam.
know.
No.
Think about it.
Yes,
Think
ma'am.
about it.
Yes, ma'am.
See, first you'll have to
Thank you.
establish what is the cause, Suresh.
Yes, that's what
I agree with Banu. There is no need for so many drugs, particularly anticoagulation with 3 antiplatelet drugs. I don't think there's any need. It's not going to sort out because obviously we have not hit the correct reason why he's going for strokes.
So can you do a 3-day thing holter, sir?
Yes, madam.
Now they do long-term holter, no? 3 days or 7 days to pick up AF.
Sir, what is the
That be
current
possible?
LDL triglyceride level?
Sir, currently the LDL is 128 and triglyceride is 282, sir.
So why don't you try some other drugs? Ezetimibe
Yes, sir.
or
Yes, sir.
inclisiran?
Okay, we'll do that.
In that way, we may prevent the next stroke.
Okay, sir.
Yeah, the main.
Sir, I've got a basic doubt in this case, sir. He is a diabetic who's getting recurrent. His blood sugar was one time it was 450. Was it under control? Was he a smoker? And what about his infarct, following which what type of symptom he had? And he had right sort of left occipital lobe infarct. And does he have hemianopia? Nothing is mentioned. And all are focusing towards the etiology of other things, apart from uncontrolled diabetes. Was it under control? At any time, he used to say, you are all talking about antiplatelet, anticoagulant, and other things also, anti-lipid agent also. There is no evidence of hyperlipidemia. Hyperlipidemia is only secondary to uncontrolled diabetes. That is a basic teaching. Basic teaching is that fats burn in the fire of a carbohydrate. I think basically what was the diabetic status like? And he has had multiple large vessel vasculitis is extremely rare. It is only giant cell arteritis or Takashi's arteritis. Other things are not all small vessel, and you have shown only small vessel involvement. And what about his diabetes? From the beginning, since what age it started, and how was it getting treated? How was it managed? And he has developed all the complications of CKD, CAD, CVD, all those things. That is my basic doubt.
Sir, his blood sugars are, this admission it was high, sir. And his wife is a staff nurse actually, and she monitors her diabetes level with GMR actually. And she says it's consistently between 200 to 220, and he's getting insulin, sir, Mixtard. So it's under, reasonable control, not
At
great
what
control.
age insulin was started?
Sir?
At what age insulin was started?
Insulin has been started for the past 3 years, sir. After his third stroke, we shifted him to insulin, and because he also developed CKD, we thought insulin will be
So
better.
obviously his diabetes was worsening.
Yes, sir. True, sir.
So it is a pure and simple case of uncontrolled diabetes with complications. That's all.
Sir, how will you prevent strokes in such scenarios, sir? Now it is under control. So what will be the drug to use for stroke prevention now?
You control the diabetes, I think you have to think of statins and other things.
Already on statins, sir.
Already patient is on statin, fenofibrate.
Even when he is on statin, when the diabetes is not controlled, your statin will not work.
Should we use antiplatelet or not, sir?
Any time we have to use that. We have to use that because definitely he has got evidence of infarct. But I think the primary factor of diabetes has to be controlled very
yes, sir. That is agreed. But should we use oral anticoagulant or just antiplatelet drugs?
Antiplatelet is enough. Anticoagulant, I don't think there's any evidence here. Evidence to use that, yeah.
Thank you.
Thank you.
Sir, Dr. Ramakrishnan, sir.
Yeah.
Hello.
Hello. Good morning.
Good morning, sir. For me, it looks like an embolic stroke only. It doesn't look like a large artery disease also, sir. Actually, we have to definitely do vessel wall imaging to look for whether it's atherosclerotic or vasculitis. He doesn't need rituximab. He doesn't look like that. Probably cardiac MRI might be helpful. If despite being on statins and phenofibrate, his LDL is, see, we expect we need his LDL to be around 50, 40 like that. At least definitely less than 70. So if he's not coming down, probably you have to go for inclisiran, this PCSK9 inhibitors. That might help. What is his HbA1c latest one?
Sir, 9, sir.
So that also should be, we have to take care. But it doesn't look like vasculitis because so far it is a mixture of both and it's of multiple territories. Probably anticoagulant alone should be enough. And you can look for clopidogrel resistance also. In that case, you can go for ticagrelor. That is my suggestion.
Okay. Doraraju, you proceed further.
Sir, for further workup, we have to do repeat angiogram, sir, CT angiogram to confirm whether it is in the same occlusion is there or not by percentage of stenosis. Also, vessel wall MRI, which helps to differentiate whether it's a concentric enhancement or the eccentric enhancement, which differentiate atherosclerosis versus vasculitis there. And also whether it's an intramural hematoma or is there any plaque composition, there is intraplaque hemorrhage, and which helps, sir. But because of renal dysfunction, we are not able to do so.
Yeah.
And another investigation planned is prolonged cardiac monitoring with a loop recorder to detect any cardioembolic source.
I think that is what is more informative going to be.
Thank you for the excellent presentation. Next, I invite Nivedini. When reperfusion backfires.
Good morning, sir.
Morning.
Shall I start, sir?
Yeah, please.
Myself, Dr. Nivedini, DRNB resident from the Department of Neurology. I'll be presenting a case when reperfusion backfires. This is a case of 66 years old male, a mechanic by occupation, presented with the chief complaints of slurring of speech and weakness of left upper and lower limb for the of 1 hour duration. History of presenting illness. Patient was apparently normal until 5:30 p.m. on the day of admission when he noticed slurring of speech of sudden onset, which resolved spontaneously within 5 to 10 minutes. After an hour, patient again developed weakness of left upper and lower limb associated with the numb. Along with the weakness, patient had slurring of speech but able to comprehend. Weakness did not improve this time nor worsen. No history of double vision, dysphagia, giddiness, unsteadiness, or swaying while walking. No history of headache, seizures, vomiting. Past history. He's a known case of diabetes for 2 years on regular medication and his DM is under good control. He had no history of hypertension and no history of CAD, TAA, or strokes earlier. Personal history, mixed diet, normal appetite, normal sleep pattern. He's a chronic alcoholic. Last intake is 3 days back. Consumes 90 ml per day for 8 years. Smoker for 10 years. 2 cigarettes per day.
Anu, madam, you have to mute your mic, please.
Sorry.
Family history, no history of similar complaints in the family. General examination, patient is moderately built and nourished. No pallor, no icterus, no cyanosis, no clubbing, no lymphadenopathy and pedal edema. Vitals, pulses 80 per minute, regular rhythm, normal volume, no specific character, no radioradial delay and no radiofemoral delay. Peripheral pulses felt bilaterally and carotid pulses is also felt, no thrill or no bruit. Blood pressure 160/90 millimeters of mercury. Higher mental function, patient is conscious, obeying oral commands, fluency is impaired, comprehension normal, repetition is impaired, and was not able to read, write, and copy, which was consistent with expressive aphasia. Cranial nerve examination, first, second, 3, 4, 6, and 5th cranial nerves are normal. 7th cranial nerve, the angle of mouth is deviated to the right side. Rest of the cranial nerve examinations are normal. Motor system examination, bulk is normal. Tone on the left side, it is decreased in both upper and lower limb. Power in the left side, it is 0/5. Deep pennant reflexes are present. Plantar is extensor on the left side. Sensory examination, touch, which is decreased over left upper limb and lower limb, cerebellum, not able to assess on the left side. Other system examination, cardiovascular system, S1, S2 ear, no murmurs, respiratory system, normal vesicular breath sounds, no added sounds. So from here, the working diagnosis is acute CVA, left hemiparesis with human facial palsy with sensory involvement. So the probable region is right thalamocapsular. From this, we proceeded with the CT brain scan. From the clinical examination, the NHS score is 12. Routine blood investigations were done and was normal. ECG showed a normal sinus rhythm. CT brain showed chronic infarct in right thalamus and left external capsule. This is the CT brain of the patient showing chronic infarct in right thalamus and left external capsule. So, summary. 66 years old male diabetic presented with acute onset of left hemiplegia, that is dense hemiplegia with left human facial palsy. So this is a case of acute ischemic stroke involving right MCA territory, NHS score of 12 and aspect step. With this, we proceeded with the thrombolysis with injection tenecteplase from 2 hours onset of the symptoms. After thrombolysis, patient vitals and sensorium was monitored periodically. After an hour, patient was able to move limbs, that is power improved from 0/5 to 4/5. This is post-thrombolysis. And the NHS score improved from 12 to 4. At around 11:15 p.m., that is 3 hours after post-thrombolysis, patient suddenly became drowsy, not responding to oral commands, had a desaturation and cardiac arrest. This cardiac arrest was reverted and the patient was put on ventilator support and no history of seizure. In view of decreased sensorium, we proceeded with a repeat CT brain, which showed previous CT doesn't, initial CT brain showed only chronic infarcts. This post-thrombolysis CT picked up the infarct in the right thalamocapsular region, and in the left gangliocapsular region, there is an hypertensity with the blood fluid level and mass effect and midline shift, which is suggesting a fresh bleed post-thrombolysis in the non-infarcted area. So coming to discussion, post-thrombolysis hemorrhagic transformation. This post-thrombolysis hemorrhagic transformation prevalence varies widely, with overall radiological hemorrhagic transformation occurring about 12 to 30% of the cases, whereas symptomatic intracerebral hemorrhage occurs in about 2 to 7% of the patient, especially within 36 hours. So Heidelberg bleeding classification for the hemorrhagic transformation. There are 3 classes in which class 1 is hemorrhagic transformation of the infarcted site. It can be either petechiae, confluent petechiae or hematoma less than 30%. Class 2 is parenchymal hematoma than 30%. Class 3 is remote or other hemorrhages. So after intravenous thrombolysis, the predictors for increased risk of hemorrhagic transformation include stroke severity based on the NHS score, that is more than 14, proximal middle cerebral artery occlusion, hypodensity affecting more than 1/3 of the MCA territory, delayed recanalization, that is more than 6 hours after stroke onset, absence of collateral flow. So our patient had post-thrombolysis hemorrhagic transformation in the non-infarcted site with the blood fluid level. So we proposed 3 hypotheses. One could be anticoagulant related. Other one is double hit hypothesis. That is anticoagulant given in a suspected cerebral background of cerebral amyloid angiopathy patient. And the other hypothesis is saying silent brain infarction, that is in an asymptomatic patient. So coming to discussion of remote parenchymal hemorrhages. The European Cooperative Acute Stroke Study defined remote parenchymal hemorrhages as single or multiple hemorrhages that appear in brain regions without visible ischemic damage detected by the CT scan, remote from the area causing the initial stroke symptoms. The incidence is 1.3 to 3.7%, and it has a poor outcome. So this is a case report. Remote intracerebral hemorrhage after intravenous thrombolysis. This is the results from a multi-center study. This study studied a sample size of a 992 population, in which they showed 18 patients had remote parenchymal hemorrhage. So coming to the next hypothesis, that is hemorrhagic transformation of a recent silent cerebral infarct. during thrombolytic stroke treatment. This is one case report where a 60 years age old patient admitted with the complaints of sudden loss of power in a right arm and a leg, right-sided facial weakness, and difficulty in speaking. The patient was undergone with intravenous thrombolytic treatment. During the thrombolysis, a small cerebral hemorrhage was suspected, and the CT showed a small hemorrhage in the right frontal cortex. This silent cerebral infarct causing hemorrhagic transformation post thrombolysis usually results in a petechial hemorrhages, in which this is the CT of this reported patient, in which the petechial hemorrhages is seen in the right frontal cortex. Whereas in the B and C picture, which has picked up the right caudate nucleus chronic infarcts. This is another case series which studied the effect of silent brain infarction and hemorrhagic transformation and progresses in patient with acute ischemic stroke after intravenous thrombolysis. So from this, the AHA has given the definite definition for the silent brain infarction, which refers to a patient who has no history of stroke or transient ischemic attacks, but a cerebral infarction or encephalomyelial changes are found on the CT or MRI with no corresponding symptoms and signs of neurological impairment. Compared with the symptomatic cerebral infarction, the lesions of silent brain infarction are usually relatively smaller in size and may have undergone a chronic ischemic preconditioning process, contributing to the absence of clinical symptoms. So the prevalence of silent brain infarction could be 10 to 20%. Studies have found that it is present about 33.4% of patients with the first ever ischemic stroke. The risk factors include advanced age, hypertension, diabetes. Most silent brain infarcts commonly occurs in the basal ganglia subcortical, which are 3 to 15 millimeter in size, wedge-like, ovoid, or irregular in shape. So in our patient, because of the presence of blood fluid level in the non-infarcted site post thrombolysis, hemorrhagic transformation is more likely due to anticoagulant. Thank you, sir.
Thank you. Nimedra, the problem is the initial slurring of speech, which can be explained probably in the left MCA territory, TAA, first side. Then she recovered from that. Then she developed a left-sided weakness, probably explaining the right MCA. So there may be a block in that. There may be a thrombus or embolic manifestation, which would have aggravated following a thrombolysis, as you rightly pointed out, the covert brain infarct, CBI. That may be the reason why the anticoagulant, that is thrombolysis induced to bleed in that left MCA territory, because of the massive in nature and involve the not only the area, internal capsular area, external capsule, and the insular region has got an arrest and get revived. So that may be the one reason. So there may be two territories involved. If you take an MR, it should pick up the area of this right MCL as well as the left MCA.
Okay, sure.
I have a basic doubt. Sorry, you've been harping saying that it's a silent brain infarct. It was not a silent brain infarct. He had a lesion. He had signs. He had symptoms. Only
Yes, sir.
it's a CT negative brain infarct.
Yes, sir.
You don't call it as a silent brain infarct.
Okay.
So it was a CT negative brain infarct. It was an infarct anyway because it produced the symptoms and signs on which you thrombolized and
Yes,
it
sir.
became a hemorrhage. So it's a hemorrhagic transformation of a CT negative brain infarct. So
Yes, sir.
you can't say it's a remote one. It can be in the same area. If
Yes, sir.
CT was done quite early, we do not know what has happened after that. We have not had an MRI. So it's a CT negative brain infarct which had gone in for a hemorrhagic transformation. That would be how I would put this whole picture.
Okay, sir.
Why MRI was not taken any time? You have not even thought of MRI?
No, sir. After post thrombolysis, after 1 to 2 hour, patient worsens, sir. So we and was connected to mechanical ventilator. So we were not.
Immediately following thrombolysis, he worsened. Did he worsen immediately?
Because he was intubated, probably that may be the reason for shifting there and other things, sir.
Why did he go for a cardiac arrest? Nivedini.
He had a desaturation, sir, and a hypotension followed by cardiac arrest, sir. Initially, he had desaturation, sir.
Was he being monitored after the thrombolysis?
Yes, sir. Periodically, we were monitoring. So blood pressures and vitals were under control, sir.
How many hours after thrombolysis he went in for cardiac arrest?
3 hours, sir.
Any previous cardiac illness?
No, sir. No cardiac. Only diabetes he has, sir.
LV is okay because the first left MCA is probably embolic, then right that causes left hemiplegia. After that, is there any LV?
We did bedside echo, sir. It was normal, sir.
Okay.
CTS, any comments? Suresh, any comments, Suresh?
Yes, sir. So this case we presented to highlight this, association of bleed in a non-infarcted area, and everything has been discussed, sir. Thank you, sir.
As a non-infarcted, it was not picked up. It was an early CT.
Yes, sir.
It was
not picked. Yes,
CT negative. Yeah, right.
Thank you. We'll move to the next case.
Yes. Thank you, sir.
Hematology meets neurology.
Oh, difficult subject.
Good morning, sir.
Yes, sir.
Nivedini, stop your
sharing.
Stop sharing. Good morning, sir. Can I proceed, sir?
Yeah, please.
Yeah, sir. Good morning, sir. Myself, Dr. Vijay, sir, from Department of Neurology, Natarajan Government General Hospital, first year neurology resident. Today, I am presenting a case of 80 years old male patient was brought to our emergency department in an unresponsive and unconscious state. History of present illness. Patient was apparently normal 2 days back. When he went for brushing his teeth, he was able to grip the brush normally as it slid and fall. In an hour time, he went into an unconscious state, which is not associated with any headache, vomiting, diplopia, or involuntary movements. No history of chest pain, palpitations, profuse sweating, abdominal pain, vomitings, or fever. Patient taken out to the nearby hospital where the CT scan was done. He got admitted, and that CT scan revealed left metacerebral artery territory ischemic stroke with mass effect. In view of poor GCS, patient got intubated and started on non-invasive mechanical ventilation. Patient was initiated on dual antiplatelets and statins. On day 2, patient developed one episode of generalized tonic-clonic movements, which lasted for less than 5 minutes, which was managed with first-generation anti-seizure medication. In view of left pupillary anisocoria and decorticate posture, a repeat CT brain was done, sir, which showed hemorrhagic transformation with midline shift, mild midline shift less than 3 mm. And patient was referred to IR center for decompressive surgery. So patient got admitted in our hospital, sir. Past medical history, known case of coronary artery disease, NSTEMI on regular medication. Personal and family history insignificant, non-smoker and non-alcoholic. On examination, patient moderately build and nourished, no pallor, icterus, clubbing, cyanosis, kyphoscoliosis, lymphadenopathy or edema. BP 140/80 mm of SG on supine position, heart rate 112 per minute, normal volume, character rate and no delays. Saturation 98% and invasive mechanical ventilation and volume control mode with FiO2 80% and temperature 98.6 per minute. At the time of initial examination, patient was comatose, not opening eyes to deep painful stimulus. Left pupillary anisocoria was present, oculocephalic reflex was present, facial asymmetry was present, and gaze reference towards the left side, and there is no skew deviation. ET tube in situ, there is no spontaneous movements present. Hypotonia over right upper limb and lower limb. Right plantar was extensor. This is the CT showing non-conscious CT showing hypotension involved in the left MCA territory. This is the CT showing hypertense lesion within the hypodensity, suggesting the acute parenchymal hematoma. And these are the investigations. On routine investigation, we found a marked leukocytosis like WBC count 1,27,000 and platelets 80,71,000 and raised ESR 60 and ECG 2D echo CV Doppler was normal. And in view of leukocytosis, we advise the peripheral smear. In that peripheral smear, we find there is an finding suggestive of chronic myeloid leukemia with more than 20% of blast cells in the peripheral smear. And they advised immunocytochemistry investigation. And we started him on anti-seizure medication, anti-edema measures, sedation with benzodiazepams. In view of rising intracranial pressure with midline shift, neurosurgery opinion was shot out and advised conservative management. In view of CML with the blast crisis, hematologist opinion was shot out and advised with the imatinib therapy. And imatinib therapy, it is a tyrosine kinase inhibitor first generation. And other supportive medications, broad spectrum antibiotic coverage was initiated. On day 2 of admission, patient was comatose, not opening eyes to deep painful stimulus. Pupillary anesthetic chorea is present. Oculocephalic reflex was absent. Corneal reflex was absent. And the patient has persistent decorticate posture with the bilateral plantar mute. And patient cardiac monitor showed bradycardia to asystole. According to the ACLS protocol, CPR done for 20 minutes, but there is no return of spontaneous circulation. Patient will succumb into illness. Coming to the summary of the case, we presented a 80-year-old male patient with a background history of coronary artery disease who was brought to emergency department in an unresponsive and unconscious state. On initial neurological assessment, the patient demonstrated a right-sided hemiplegia with right upper motor neuron facial palsy, clinically localizing to the left hemisphere. Blood pressure was normal within the limits at the time of admission and at the time of our arrival. So it generates a common cause for the bleed. So we done a non-contrast component tomography blood reveals like striking combination of two current lesions and a left basal ganglia bleed with characteristic consist of parenchymal hematoma and a left meridian artery territory ischemic infarct with an associated midline shift of 7 mm indicating that there is a mass effect. The coexistence of both hemorrhagic and ischemic lesion in a normotensive patients prompted a comprehensive hematological workup which revealed an underlying chronic myeloid leukemia with circulating blast cells, a diagnostically and critically and clinically unifying finding that is finding. So we postulate that CML itself served as a common underlying etiology for both ischemic and hemorrhagic cerebrovascular event, likely through mechanism include hyperviscosity, blast-mediated endothelial injury, and coagulopathy inherent into the disease state or due to the blast crisis. After that, we go on the literature stage. In India, only a few cases or 1 to 2 cases are presented like this. In that, there is an promyelocytic blast phase chronic myeloid leukemia presenting as ischemic though, but patiently previous on diagnosed with CML with on imatinib therapy, he developed ischemic stroke. And another case. This is another case where CML with blast crisis de novo, we are presenting as an acute intracerebral hemorrhage. And these are some other studies which are done in India. There, the patient primary presentation is like there is a bleed inside the intracerebral cavity. Ischemic presentation is very rare. So according to the WHO criteria for blast crisis is defined as presence of more than 20% or more blast in the peripheral blood or bone marrow, or a large focus of blast cells within the bone marrow, or there is an extramedullary blast proliferation. This is the criteria given for the blast crisis. Coming to the pathophysiology, there is an reverse translocation between the 9 and 22 chromosome of the BCRL and ABL that causes the CML. In case of CML with the blast crisis, there will be an extreme leukocytosis will be there. That extreme leukocytosis causing ischemic microvascular occlusion. Sometimes it can cause conjunctive coagulopathy, like it can present with disseminated intravascular coagulation with thrombocytopenia. They can present with the hemorrhage into the ischemic territory or in a separate territory. These are the other mechanism proposed like extreme leukocytosis. Uriological failure means there is a blast aggregation. Blast cause endothelial adhesion, causing platelet aggregation, and there is an oxygen paradox. Blast cells are utilizing more oxygen than the brain parenchyma, and there will be a microthromby due to the blast cells and aggregation of the platelets, and there is an activation of endothelial factors. These are the other mechanisms that are proposed. It can be cause for acute ischemic stroke in a CML patient with blast crisis. Coming to the discussion on leukemia and stroke, chronic myeloid leukemia makes up 15% of the diagnosis of adult leukemias, with the median age of diagnosis being 67 years and old. Chronic myeloid leukemia consists of 3 phases: chronic phase, accelerated phase, and blast phase. Most patients are initially diagnosed while in the chronic phase. Of the diagnosis of chronic phase being treated with tyrosine kinase inhibitors, about 1 to 1.5% of CML patients per year is subsequently transferred into an advanced phase or blast crisis phase. Blast crisis is then considered as an oncological emergency with increased mortality occurring primarily from the subsequent infections or rebleeding. Chronic myeloid leukemia is a myeloproliferative neoplasm characterized by reciprocal translocation of ABL1 and BCR region of chromosome 9 and 22 respectively. Ischemic stroke as a presenting feature of blast phase progression in CML is extremely rare because thrombosis in CML is not well defined. Thrombosis can be seen in patients with acute promyelocytic leukemia, with venous thromboembolism is the most common cause. Arterial thrombosis is very rare. And 1/4 of the patients presented with blast phase without the pre-existing chronic phase, or patient is presented in a blast phase without any previous CML diagnosis. So coming to the treatment, in acute phase, we can treat with the hydroxyurea. That hydroxyurea as a definitive diagnosis, until the definitive diagnosis is made, it will help to cytoreductive, it will reduce the risk of rebleeding. And tyrosine kinase inhibitors, especially those with high intracranial permeability, can be used. Dasatinib is a second generation tyrosine kinase inhibitor with high intracranial permeability. Dasatinib effectively reduces the normal granulocytes in CSF and controls the body temperature, and demonstrating its effect on the intracranial lesion. In case of mass effect, surgical intervention with reconstructive craniectomy can be done. Coming to the conclusion, ischemic stroke followed by hemorrhage in a patient with CML has not been reported in India till now. This also open up a causes of lesser known etiology of ischemic stroke, like Toast classification of determined etiology with rare causes, and also hemorrhagic stroke.
What was the WBC count in your patient?
Sir, 1,27,000. 1,27,000, sir.
And why do you say it's unusual to cause ischemic stroke with that high WBC count?
Yes, sir. Initially, we did not suspect it, sir, but after doing CPP only, we suspected that there is an immunological malignancy, sir, leukemia, sir.
That is true. You are saying ischemic stroke is uncommon in a blast crisis. If the count is were to be 1,27,000,
sir,
definitely there are so many WBCs which is going to clog the vessels. It will certainly produce stasis, hemostasis, and produce an ischemic stroke.
Sir,
why do you say it is rare?
Sir, yes, sir, true, sir. But on literature search, we found only venous thromboembolism, hemorrhage, sir. But in India, so many studies are done, sir. All are presenting with hemorrhage only, sir. But in our case, first initially presented as ischemia, followed by converted into hemorrhage. Sir. That is the rareness of our case, sir.
No. What was the platelet count?
Sir, platelet count 8,71,000, sir.
Sorry, 87.
8,71,000.
That also was increased.
Yes, sir. Yes, sir.
Okay.
Yes, sir.
So we have two reasons for ischemic stroke.
Yes, sir.
Yes, sir. Comments.
So you mean to say that the leukemia, chronic myeloid type, will not produce ischemic stroke? That is the message of this discussion.
Sir, it depends on the stage, sir. Generally, in case of accelerated and blast phase, there will be prolonged leukocytosis can cause ischemic stroke, sir. But in India, the number of presented cases are less, sir.
So just because, it has not been presented, you are right. You are very cautious in saying, in presented cases, hemorrhagic strokes are more common.
Yes, sir. Yes, sir.
That you can say. Because leukemia we see quite often in an oncology unit.
Yes, sir.
Where several types of, and here it is a chronic, he came with myeloid crisis. Was it diagnosed before anywhere?
No, sir. Nowhere it is diagnosed.
He is 80 years old without any cerebrovascular problem in the small vessel disease in the brain.
Yes, sir. Yes, sir. Sir, mild locular infarcts are there, sir. That is not significant, sir.
Multi-infarct. What was the previous status of him before the onset of the illness? He was absolutely normal.
Sir, he was absolutely
Talking
normal,
about
sir. Able to do all his daily activities routine normally, sir.
the age of 80 years.
Yes, sir. Yes, sir. He able to walk, able to go to a ground and walk for about 30 minutes like that, sir.
From whom you got the history?
Sir, from the wife only, sir.
Time it always why he was not diagnosed? Any other organomegaly or sort of?
Sir,
I don't think
we done USD abdomen, sir. That splenomegaly is there, sir.
splenomegaly was there.
Yes, sir.
At no time he had bleeding episode at no time before.
Yes,
like
sir.
when brushing teeth, producing. Because
Yes,
I'm surprised because we see several cases of leukemia we have seen. And chronic myeloid leukemia is something is supposed to be very benign. Benign in the sense that it's not very aggressive.
Yes,
when
sir.
compared with other CML, we see several patients accidentally. And with bleeding episodes, probably this bleeding is entirely different from CML.
Yes, sir.
Can it be due to that? Cannot be related to that.
Sir, the bleeding is mainly due to that conjunctive coagulopathy with DAC causing thrombocytopenia causing bleeding. Most studies are showing that due to thrombocytopenia only in CML there is a bleeding, sir.
He had D-dimer raised.
D-dimer we did not done. Not done, sir.
But in your patient, platelet counts are high.
Yes, sir.
Very high. Sir. Yeah. Is it related to that? What is the relative factor you said? Because most of the time, no, we have seen CML. I don't know whether the recent concept is changed or not. CML is something which is little better than other leukemias. Because most of the time, acute leukemias are very dangerous, very risky, very alarming.
Yes, sir.
And he has gone for blast crisis, that too.
Yes,
that means that he was having chronic myeloid leukemia for several years.
Yes,
and
sir.
it was not diagnosed before that. At the age of 80 years, 80 years, he would have gone to the hospital for even for small minor ailments, and they would have investigated.
Yes, sir. Yes, sir.
And how come it was missed?
Sir, asked for the previous all the reports.
Wife was there with him. Anybody else was there with him? They were alone. Both were alone.
Sir, parents are only staying here, sir. The children are settled in abroad, sir.
Oh, this is a problem. I think most of the time it happens. Most of the time, the underlying illness may not be known to the other partner.
Yes, sir.
And this is one of the problems of the old age. Old age living alone with the wife alone. And I think a wife always thinks that her husband is normal for a long time. And when the person becomes sick, only she says that she always says that he was absolutely normal.
Sure.
I don't think it is. You think in that line. Just think
Yes,
chronic myeloid
definitely,
leukemia separately, and then probably something else, because amyloid angiopathy and other things are more common in bleeding of old age.
Okay, sir.
Thank you, sir. Thank you, Vijay. And next I call upon Dr. Deepika. Dengue affects both ends of neurology.
Yes, sir.
Yeah, please go ahead.
Good morning, sir. Myself, Deepika, General Medicine resident. My topic is dengue affects both ends of the neurology. A 50 years old male hailing from Viluppuram, farmer by occupation, A right-handed person presented with complaints of unsteadiness while walking, associated with the frequent falls for the past 2 days, complaints of clumsiness of both upper limbs for the past 2 days, complaints of weakness of both lower limb for the past 2 days, and there is history of slurring of the speech for the past 2 days. History of presenting illness, patient was apparently normal 2 weeks back, after which he was hospitalized in view of dengue fever and discharged after symptomatic improvement, and he developed unsteadiness while walking for the past 2 days, which was acute in onset, associated with frequent falls, swaying to both sides, and there was history of walking with the legs wide apart, which was noticed by the family members. There was history of clumsiness of both upper limbs for the past 2 days in the form of unable to take the food to mouth due to the tremors. There was history of smearing of food on the face present, and patient also had difficulty in using both the lower limbs for the past 2 days. History of difficulty in walking, which was progressed from walking with support of the surrounding objects to the two-person support, and it progressed to unable to stand without support. There is also associated with the weakness of negotiating chappals to the feet and buckling of. There is history of difficulty in getting up from squatting position, rolling over the bed, mixing food and lifting hands above the shoulders. But however, he was able to lift the head above the pillows and there was no swallowing difficulty. There was slurring of speech for the past 2 days. His pronunciation was unclear. There were multiple pauses in between the words, but he had no difficulty in understanding the spoken words, repeating the words or naming the objects. There is able to feel the cloths over the body and perceive the insect bites, able to appreciate hot water, cold water sensation, no history of numbness, pins or needle sensation, no history of walking on cotton wool sensation. No history of diplopia, head tilt or drooping of eyelids. Patient was able to chew food and appreciate sensation over the face. Able to appreciate bladder fullness and able to initiate and control micturition. There is no history of constipation or loose stools, no history of weight loss, no history of loss of consciousness or altered sensorium, no history of memory disturbances, delusions or hallucinations, no history of heavy metal exposure, neck stiffness or neck pain. There was no history of fever or abdominal pain. Past history, there was no similar complaints in the past, but there was previous hospitalization in view of dengue fever and discharged 2 weeks back. Patient is not a known case of diabetes, hypertension or seizure disorder or thyroid disorder. There was no previous surgery, hospital admissions or chronic drug intake or alternate medications intake. Personal history consumes mixed diet, normal bowel bladder, normal sleep pattern, no habits. There was no significant family history also. Summary, a 50-year-old male presented with complaints of acute onset symmetrical ataxia in the form of gait ataxia, limb ataxia, difficulty in using both upper and lower limbs, speech difficulties, intention tremors, along with weakness of all 4 limbs, without involvement of higher mental function, cranial nerve, sensory, or autonomic nervous system. On examination, patient was conscious, oriented, moderately built and nourished. There was no pyelorectus, cyanosis, clubbing, lymphadenopathy, or edema. BMI came out to be 23.4 and there were no neurocutaneous markers. There is no evidence of skeletal abnormalities. Vitals, pulse was 90 beats per minute with regular rhythm, normal volume, normal character, no radial or radiofemoral delay. All peripheral pulses were equally felt and there was no vessel wall thickening. Blood pressure was 110/70, measured in right upper arm in supine position. Respiratory rate 12, abdominal thoracic type. Higher mental function, patient was conscious, oriented. Memory was intact, including immediate, recent, and remote memory. Speech showed a scanning dysarthria, multiple pauses between consonants. Repetition was intact. MMSE came out to be 28. Mood and affect showed no emotional liability. Cranial nerve examinations, olfactory was normal. Optic was also normal. Oculomotor, trochlear abduction, trigeminal was normal. Facial nerve was also normal. Jaw jerk alone in trigeminal was not elicited. Vestibulocochlear nerve glossopharyngeal vagus was normal. Spinal accessory hypoglossal normal. Bulk was normal. Tone both in upper limb and lower limb showed a hypotonia. Shoulder power was 3/5 in both shoulder, elbow, wrist, hand grip was 60%. Lower limb power was also reduced to 3/5 in hip, knee, ankle. Plantars was flexor, and superficial reflex, corneal, conjunctival, abdominal reflexes were elicited. Plantars flexor and deep tendon reflexes was absent. Biceps was absent. Triceps absent. Brachioradialis, knee, ankle was absent. Sensory examination. Patient was able to perceive pain, temperature, touch, proprioception, position. Then cortical sensation was also normal. Tactile 2-point graphesthesia stereognosis. Cerebellar examination showed slow saccadic movement in both eyes. Truncal ataxia was present. Finger-nose test was impaired bilaterally. Rebound phenomena was positive. Dysdiadochokinesia was present bilaterally. Heel-shin test was impaired. Patient was unable to perform unable to draw a circle smoothly. Foot tap test was positive, and gait was wide-based, ataxic, and tandem walking was not possible. Scanning speech was present, and rhombox could not be elicited. There was no extrapyramidal signs or signs of meningeal irritation. Spine and cranium was normal. There was no carotid dewey, thrill. Peripheral nerves was not thickened. Systemic examination was normal. The diagnosis is a 50-year-old male with acute onset symmetrical cerebellar ataxia, along with flaccid quadriparesis without involvement of higher mental function, cranial nerve, sensory, or autonomic nervous system. The structures involved are cerebellum, bilateral hemispheres, and vermis, with the peripheral nerves with or without radicals. Investigation. Investigation, complete blood count was normal. Other routine investigation, LFT, RFT was normal. Dengue NS1 antigen was negative, but dengue IgM ELISA was positive. Serum BDRL negative, HIV 1 and 2 was negative. Then CSF was done. It showed albuminocytological dissociation of glucose of 60 and protein of 188. CSF dengue IgM antibody was positive, but other encephalitis panel was negative. Thyroid, vitamin B12 and vitamin E levels were normal. Other infectious causes of mycoplasma, herpes, Epstein-Barr, HIV, cytomegalovirus antibodies were screened and was found to be negative. And MOG antibody NMO was also screened. Oligoclonal bands CSF was also negative. Vasculitis profile was done and was negative. Nerve conduction study in this patient showed prolonged S wave minimum latencies. Distal motor latencies were also prolonged. Conduction block was there. Temporal dispersion was present. However, SNAPS was normal, suggestive of demyelinating pattern. These are the NCS images of the patient. CT brain taken, which showed bilateral symmetrical cerebellar hypodensity, which was followed by MRI. MRI T1 was normal. However, T2 flare and diffusion weighted showed bilateral cerebellar hyperintensities, but MRA was normal. This is MRA of the patient, which is normal. The diagnosis of the patient was kept as post-infectious demyelination of the cerebellum along with acute inflammatory demyelinating polyradiculoneuropathy. Patient was started on IV steroids for 5 days along with the intravenous immunoglobulin. His weakness improved over a period of 10 days. At around day 22, patient was able to walk without support and his power became 4+. His coordination of reaching the objects and slurred speech also improved. These are some case reports which showed following dengue fever. Dengue fever can affect the cerebellum as a demyelinating feature, which is usually seen within 2 weeks of onset of fever. This is a case report showing acute cerebralitis presentation following dengue fever and GDS presentation following dengue fever. These case reports of central and peripheral demyelination has been reported separately. Confluent cerebellar hyperintensities was, however, reported only in few cases only. And the difference between cerebralitis and this restricted demyelination of the cerebellum is based on the time profile. There is also involvement of radicals nerves, which has been reported. But in our case, there is involvement of both cerebellum and the peripheral nerves involving the radicals. So this combination of involvement has not been reported yet. Thank you.
Is it specific for dengue? Any post-viral can produce both cerebellar as well as polyradiculopathy.
Yes, sir, it can produce, sir. But in this patient, other virus panel.
No, that's okay. That is okay. I accept that. No, my question was, is it specific for dengue that it causes both central and peripheral?
No, sir, it is not specific.
Yeah,
sir.
correct. That's it. Right.
How many days after dengue fever, after recovery from dengue fever, he has developed this problem?
2 weeks after fever, sir.
For 2 weeks, he was normal.
Yes, sir, he was normal. It was acute onset. Yes, sir.
At the time of dengue fever, he was admitted somewhere and was diagnosed as dengue where IgG was positive.
Yes, sir.
And he had
Got a record for that.
And then he fully recovered.
Just out of curiosity, was GQ1B antibody done?
No,
no, sir, it was not done.
Yeah, the clinical picture is not in favor of that, but still, since you did so many antibodies, I was wondering whether GQ1B also was included.
Sir, actually, sir, whenever we get a case of central demyelination and we routinely do nerve conduction, and often I see some efflatencies will be prolonged and some patients will have conduction blocks, demyelinating pattern when we do a peripheral nerve conduction, when we do a nerve conduction study. But they will not have weakness. But maybe that is a subtle presentation or a subclinical presentation. But in this patient, we had flaccid quadriparesis as well as albuminocytological dissociation, plus which also proved electrophysiologically, both central restricted demyelination and peripheral radiculoneuropathy.
CTS. CTS.
Yes, sir.
The powers mentioned were grade 3/5. It was not flaccid. It was significant. I mean, you could say there was weakness, but not extreme weakness. 3/5, that's all.
Reflexes were also absent, sir.
That's true. That is true. Yes. A reflexes. That is why I was saying whether GQ1B was tested. Of course, there was no ophthalmoparesis, ophthalmoplegia, but slow saccades was mentioned. Pancerebellar features was mentioned. Areflexia was mentioned. So all that goes with GQ1B. Only thing is the conduction in GQ1B, not all cases showed this sort of demyelination, but it's not unknown. So, so that is where we stand. In other words, could this be Miller-Fisher?
Yes, sir.
Variant. That's all.
Okay. Thank you, Deepika. Next, thank you. It's
all
all
cases well presented. Presenters
Yes, sir.
did a good job of presenting. Very well presented.
Thank you.
Yes, sir. Good training, CTS.
Sir, thank you.
Over to Suresh, sir.
And CTS team.
Yes, sir.
Yes,
sir, mine is a short presentation, sir. I have to share. So am I able to, sir?
Yes.
Yes.
Sir, it's a small presentation, sir. I mean, just before lunch, we'll break up with a dessert, sir. I think this sign everybody will be knowing actually. I thought I found out last week and I thought I'll put it. It's a neurological sign revisited.
Suresh sign.
Sir. No, sir, it's an old sign. I want to see this 2-part video, 30-second video. I want everybody to watch this closely.
Why?
Can you change the slideshow?
Yes, sir. This is the first part of the video. And this patient was referred for evaluation of myasthenia. She had left congenital ptosis. Anybody wants to take up, sir? Or I'll continue with the slide. This is the second part of the video, sir.
Can you make it a slideshow and bring it little bigger and then?
Jaw winking phenomena.
Marcus.
Reverse.
Yes, sir. No, Priya madam has correctly told it. She always tells.
Yes, that's right. She's always correct.
So it's Marcus Gunn jaw winking phenomenon, sir, actually. So, I mean, this occurs in 4 to 6% of congenital ptosis. So whenever we get a patient with congenital ptosis, we should suspect this phenomenon. And this actually doesn't come only with jaw opening. It also comes with any, trigeminal related nerve movement. I mean, opening the mouth, putting the tongue. So this patient had the jaw winking phenomenon when she was protruding the tongue outside, side by side. And the eyes started opening when she opened the mouth. And this is because of two theories have been postulated. One is the misfiring, which between the trigeminal nerve and the third nerve. And the other thing is the release theory, in which this misfiring has been inhibited, but that inhibition is becoming disconnected. So this is called, Marcus Gunn jaw winking phenomenon. And who is this Marcus Gunn? So Marcus Gunn is a Scottish ophthalmologist. His full name is Robert Marcus Gunn. He lived between 1850 to 1909. He did not show only Marcus Gunn phenomenon, but he also, brought up Gunn's dots, the AV Nick, the Marcus Gunn pupil, which he described in 1902. And he's not a neurologist; he's a Scottish ophthalmologist actually. And he had at that particular time, and when I was looking into his literature, there was a saying that all the lunatic eyes were different from normal eyes. So he went to the lunatic asylum and he checked all the lunatic eyes, and he told the lunatic eyes are no different from normal people eyes. And he also had a knack of looking at the retina of the marsupials. The marsupials are kangaroos, which live in Australia. And so he went to Australia and he researched on the retina of the marsupials. And marsupials usually they bring up their children preterm, and they put it in their pouch and they grow it. So. And this is the dot sign. This is a Gunn's dots. These white dots, right? These are normal reflection of the RNFL, which looks like a Gunn's dot. And this AV Nick phenomenon, which we find in the grade 2 hypertensive retinopathy because of the thick arterial vessel. So, and another important thing of the Marcus Gunn is a student of Argyll Robertson, who is also a famous, he's also an ophthalmologist, and he was a contemporary of R.L. Stevenson. R.L. Stevenson is a man, so he gave this, nice wordings. A man would rather leave behind the portrait of his spirit rather than a portrait of his face. So what I found in Robert Marcus Gunn, talking with his eyes and deeds, he left a portrait of not a beautiful face, which very often can get scarred, defaced, and wrinkled, but a work which is spoken almost 150 years later, sir. Thank you.
Thank you, CTS. Thank you.
Thank you, sir. Thank you.
Yes, Justin, we have finished in time.
Yes, sir.
6 presentations in 2 hours. Very well done.
Yes, sir. All cases are well presented, sir. Extraordinary cases, and telling the exam points to the students also, and learning curve for the everybody, sir.
Yes, sir. Suresh, any comments?
Sir, all the videos have been till December 2025 has been uploaded, sir, in our group. I have left it in the chat box.
Okay.
And these 4 videos also will be uploaded in this week's time, sir.
Okay,
so
okay.
Can have a look.
Thank you, thank you, thank you.
Thank you, sir. Thank you, sir.
Thank
Thank
you.
you, Suresh.
Thank you,
Suresh,
sir.
thank you for uploading the videos, because many times Sundays I don't attend. This week I'm free, I attended, and I see the videos later. Thank you so much, Suresh.
Thank you, madam. Thank you, madam.
Banu used to say that to me, that
Yes.
she always sees it later.
Because Sundays usually I am busy with other works. This week I'm free.
Yes, madam.
Yes, sir. Thank you, sir. Nice meeting.
Thank you, Justin. Thank you,
sir. Thank you very much, sir.
Thank you, Suresh. Thanks, the department.
Thank you, Suresh.
Neurology at Indira Gandhi Institute. As I said, all cases were very well presented by the postgraduates, and that shows the training which is imparted to them by the department. Thank you. Thank you very much.
Students, sir.
Thank you, sir.
Thank you, sir.
Students like teacher, like student.
Thank you, madam.
Who is that? Who gives that comment?
Madam,
Me,
sir.
Banu, sir.
Oh, yes, ma'am.
Like me and sir, like Suresh, like student.
Oh, you are linking us, is it? Oh.
Thank you, madam.
Thank you,
Thank you,
thank you.
madam. Thank you, madam. Thank you.
And thank you, Sun Pharma, as usual, for all the logistic support. Thank you very much. We'll come back next month. Thank you. Thank you, Suresh. Thank you. Thank you, Justin.
Thank you, sir. Thank you very much, sir. Thank you, Suresh, sir.
Thank you, madam. Thank you. Thank you,
And
sir.
thank all the discussants, Professor Alagasan, Professor Meghandan, Dr. T.C. Ramakrishnan, all of you. Thank you very much. I might have missed on some who I did not identify. Thank you.
Thank you,
Thank
sir.
Ibrahim, can we leave? If Sun Pharma people, Sun Tech support team, can we leave?
Yes, sir.
Okay, thank you. Thank you so much. We'll come back next month. Thank you.